The discussion has really been about testosterone replacement. I'm coming at it from the other perspective, which is androgen deprivation and intermittent therapy, testosterone levels in men on prostate cancer, what we've learned recently about the importance of testosterone suppression. And it's an interesting sort of counterpoint to Abe's perspective, which is that testosterone doesn't seem to be relevant in prostate cancer. Definitely a controversy there, but my focus is really in men who have recurrent, biochemically recurrent or metastatic prostate cancer. What's the significance of testosterone on treatment? So I have many disclosures and have worked with most companies in this area and have no allegiance to any of them. What have we learned in the last decade about androgen deprivation therapy and prostate cancer? Much more about therapy-induced mechanisms of resistance. So these prostate cancer cells are very shrewd. They have acquired over the millennia many treatment-induced survival pathway mechanisms that allow them to survive despite our attempts at eradicating them, including things like splice variants, a switch that is turned on by androgen deprivation that results in the synthesis of an androgen receptor that is lacking the ligand binding domain and is constitutively active, unlike all other steroid hormone receptors, which are inactive if they lack the ligand binding domain. The androgen receptor remains active. The metabolic effects of ADT, this is now the 10th anniversary since the Nancy Keating article reporting what a lot of people knew intuitively, but it hadn't really been documented, that there are very significant metabolic effects and systemic effects of ADT beyond loss of libido and so on. We have some data from large randomized trials on intermittent therapy, still somewhat controversial. I'll come back to that, on the impact on survival. The importance of testosterone levels, the antagonists over the last 5 or 6 years, some potential benefits in terms of reduced cardiovascular events. And of course, we now know what was not clear 4 or 5 years ago, that despite the development of castration resistance, the androgen receptor pathway is still very active, targetable. The new AR pathway targeted agents are effective despite the fact that patients are seemingly castration resistant. So just a couple of comments about this well-known table or pathway of the various ways in which androgens are synthesized. And the main points are, first of all, the upregulation of the backdoor pathway in men with CRPC. So what happens, and you can see in the top right, there is very dramatic upregulation of some of the key enzymes required for synthesis of androgen precursors that takes place in the castration-resistant state. So this is androgen-independent prostate cancer compared to intact men with normal prostate. And you can see AKR1C3, this key enzyme, is involved at several points here in the synthesis of DHT from dihydroprogesterone. It's called backdoor because it does not go through testosterone, which is here. So there's the normal cholesterol pathway, which we pretty much abrogate by castration, and what happens is intracrine synthesis of androgens by prostate cancer cells. So this has been very well documented. The other aspect of this is not so well known is this one here, of course, the adrenal pathway, and a key molecule here is dihydroepiandrosterone, which acts as a precursor for testosterone in the castrate patients. Now, testosterone, of course, is a lipophilic molecule, diffuses at equal concentrations into all cells. The cells that are androgen sensitive have the receptor expressed and the others do not. In the castrated male, DHEA, a polar molecule, dihydro, is transported into the cell, not by diffusion. It requires an active transporter and serves as a precursor for testosterone and binding to the receptor, etc. So there's some interesting data recently It turns out that statins require the same transporter to be transported into cells, and it's called SLC02B1. And there's evidence that statins compete with dihydroandrosterone for transportation into the cells. And therefore, the plausible hypothesis is that statins reduce the availability of this testosterone precursor in prostate cancer cells and therefore have a beneficial effect in preventing castration resistance. And there is a recent clinical trial in men on ADT, statins versus no statins, actually showing improved time to castration resistance. So this is a very kind of provocative observation. I'm very pro-statin. In my opinion, certainly most men on ADT should be on statins based on the preclinical data that it may be relevant in terms of intracellular testosterone levels. And second, here is clinical data that it actually works to improve the outcome. Now, intermittent therapy, I see Juanita Crook, my co-author, is in the back. I'm sure she might have some comments about this. 20 prospective phase 2 series. Juanita and I were co-authors on the Bukowski one. This was my original trial now more than 30 years ago, and there's about 10 phase 3 trials, mostly a mix of patients, a whole range of induction periods from 3 months to 10 months. Results very consistent. None of these trials, which were admittedly smaller in most cases, showed any adverse effect of intermittent therapy on time to progression, prostate cancer survival, and so on. But then 4 or 5 years ago, we had these two, what were considered pivotal trials. Juanita's trial of intermittent suppression for patients with biochemical failure, mostly post-irradiation. And this trial had a very clear outcome, almost 1,500 men, 10-year follow-up, absolutely no difference in overall survival. Again, biochemical failure, non-metastatic. The clear message from this trial is that intermittent therapy in that setting has no adverse effect on survival, and I think that the result is that intermittent therapy for men with PSA failure is widely utilized, and it should be. The one sort of provocative clue in that study was that there was a difference, not significant, but a trend in cause of death. The top two lines are non-prostate cancer mortality, so a trend to more non-prostate cancer deaths in the continuous arm. Not surprising given what we know about insulin resistance, change in lipid profile, cardiovascular events, etc., and an almost matched trend to more prostate cancer deaths in the intermittent arm. Again, p.13, so not significant. You can make whatever you want out of that. More controversially, you had the SWOG 9346, Maha Hussein. Same size of trial, about 1,500 patients, metastatic disease. Not so clear cut. A non-significant trend to more overall deaths, almost all from prostate cancer, because these are now men with metastatic disease, much higher likelihood of dying of the disease. But crosses unity, hazard ratio 1.09, conclusion, unequivocal statement in the article in the New England Journal, results inconclusive. A conclusion that was not accepted by the authors, by the way. And they have written about this quite extensively. It's an interesting phenomenon where you have authors who don't accept the conclusions that are mandated by the editors of the journal. And the reason was, in the minimal disease category, it almost reached significance, showing worse outcome in the intermittent arm. And the authors have written that this should be interpreted as being intermittent therapy is not advisable in men with metastatic disease. And, this is a controversy that continues. This is a meta-analysis published a couple of years ago. It just shows if you lump all of the relevant trials, metastatic, non-metastatic, both, no difference in overall survival, PFS, no difference, CSS, no difference, non-prostate cancer mortality just about reaches significance, showing a benefit to intermittent therapy. The one, I think, key observation from the 9346 trial is the incredible power of PSA response to predict mortality in men with metastatic disease. So you can see the complete PSA responders have more than 6-year median survival. The non-responders with PSA above 4 after 7 months, 1-year median survival. So I don't think we acknowledge enough how powerful that biomarker is in this setting. Testosterone recovery. This goes back a ways, 10 years. This was some gorgeous data. Nick Brukowski, who I'm sure many of you know by reputation, and took an endocrinologist's approach to testosterone and PSA and ADT. And this was a phase 2 trial. Juanita was also involved in this one. 100 men with radiation, post-irradiation rising PSA with intermittent therapy. So this is testosterone recovery, cycle 1, 2, 3, 4. You can see, first of all, that the majority of men do recover testosterone within the first 6 months or so, but that recovery tends to get attenuated with each cycle. The testosterone tends to recover less, the PSA tends to recover more quickly. This is a summary of this cycle 1, 2, 3, 4. So you see about 75% of patients have recovered testosterone to above 7.5 nanomolar, which is the equivalent of about 250 nanograms per deciliter. Just one other study more or less shows the same thing, that testosterone recovery occurs in most patients by around 6 months. And then this is some brand new data. We just completed a study called the FIT study. No one had ever looked at the induction period. So the Portuguese paper, which was 1,000 randomized patients, was only 3 months of induction and actually showed no difference, but a mixture of patients and some other technical issues with that study. We used 8 months in the PR7. The SWOG 9346 was 7 months. So we just completed a randomized study comparing induction period, 4 versus 10 months of degarelix, to see whether that influenced the duration of the off-treatment interval. No one ever tried to nail that down, and somewhat to my surprise, absolutely no difference between the two arms in the duration of the off-treatment interval. And I'm not going to show much of this data. This is just not the major focus, but here's time to testosterone recovery. And again, no difference whether you induce with 4 or 10 months. So the suggestion is maybe we're inducing too long. Maybe you only need, probably what you should do is treat to PSA nadir below 0.1 and then stop. Quality of life, the data is not as clear-cut as you'd expect. So I think anyone who treats patients with intermittent therapy knows, based on simple clinical observation, that patients feel better off treatment as a rule, their quality of life improves, patients prefer not to be on this therapy if they have the choice. And you look at all these randomized trials, and pretty much most of them that have looked at quality of life show benefit, but the data is not that compelling. It may relate to the limitations of the instruments that are being used, that they don't capture things like hot flashes and so on. The data that's out there supports a benefit in terms of quality of life. Now, it's not completely straightforward. This is a recent, very counterintuitive result reported again by Maha Hussein, who's become sort of the chief proponent of continuous therapy. And they went back and linked the SWOG 9346, that's the 1,500 patients with metastatic disease, randomized intermittent versus continuous therapy, to Medicare data and pulled out the cardiovascular event rate. And I think to most people's surprise, found a significant increase in ischemic thrombotic events and ischemic heart disease in the intermittent arm. And, why that is I think quite interesting. Why should less therapy result in more cardiovascular events? It may be related, for example, to periodic stimulation of LHRH receptors in endothelial plaques by the LHRH agonists. And each time you retreat, you are kind of stimulating these endothelial macrophages, potentially destabilizing plaques. But that's just, in the PR7, we saw no evidence of an increase in cardiovascular event rate. It's a little hard to understand. Next point I want to make is about the significance of testosterone in men on treatment. So this has been a controversy for at least 10 or 15 years. Every LHRH manufacturer is falling over each other to try and prove that they get lower levels of testosterone. Does it really matter? And there are these several studies that have been reported, non-conclusive, that suggested it mattered. The commonest one that was quoted was Marodi, published in 2007. Only 72 patients, retrospective, dramatic differences in outcome depending on the testosterone was below 20, intermediate, or above 50. And frankly, I didn't believe this. We had the opportunity with this PR7 trial, we had about 750 patients on the continuous arm with serial testosterones. So we published this last year, the 626 evaluable patients on the continuous arm. What was the impact of their testosterone level on outcome? And we got a very clear result, which was the patients whose testosterone was fully suppressed below, we use nanomolars in Canada. The conversion is 28, so 0.7 is equivalent to 20. Who had a median testosterone below 0.7 or 20 in the first year, had dramatically improved time to progression with a hazard ratio here of about 2 compared to the ones who were fully suppressed. Fully suppressed, 2 times better in terms of progression to CRPC than the ones particularly the ones whose testosterone was not below 50. And this is cancer-specific survival, same phenomenon, better with lower testosterone. There's now about 8 studies in the literature, 7 of which show exactly the same thing, which is that lower testosterone in men on treatment is associated with better outcome and time to progression and prostate cancer survival. Now, there's a conundrum there, because you stop testosterone, you stop ADT, the testosterone rises. Intermittent therapy looks pretty good. No one's been able to show conclusively that it gives worse outcome, and yet the testosterone rises. And here we have evidence that higher testosterone is bad for patients when they're on ADT. So this can be reconciled. It's an apparent paradox, but the idea is that there are, if you simplify it, in the untreated patients, 3 cell types. The stem cells, which are androgen resistant, don't express the receptor. This is well established. The yellow cells, which are the normal prostate cancer epithelial cells, which die in response to any significant drop in testosterone. And then the green cells, which are partially sensitive, partially resistant. So these are the ones that only die if the testosterone is driven down below 20. And so you think about the untreated patient, you're starting intermittent therapy. So you treat, you drive the T below 20 or 0.7, you end up with only the stem cells surviving. These 2 compartments undergo apoptosis, and on testosterone rising again, you get repopulation with androgen-sensitive phenotype. However, if you don't hammer the testosterone below 20, you're left with the green cells. You're left with a more heterogeneous population of partially resistant cells on repopulation. And of course, with time, you get selection, pressure, and adaptation results in castration resist, but it takes more time. So the basic message here is the fact that low testosterone is important on treatment doesn't mean you have to continue treatment lifelong. You need to hammer the cells. When you stop treatment, the idea is that the more favorable cells repopulate as a result. An implication of this idea that low testosterone really is important in men on ADT, you can take it a step further. Androgen annihilation, which has been coined by Jim Mohler, and the idea is you don't just lower testosterone as much as possible, you do everything else. You treat with Abiraterone to block intracrine synthesis of androgens and adrenal androgens. You treat with an androgen receptor antagonist like enzalutamide to block any ligand binding. You even treat with a 5-ARI just in case there's a little bit of testosterone getting through, being converted to DHT. And the idea is this much more aggressive approach of simultaneous 4-pathway targeting of the androgen receptor might actually make a difference. And the proof that this has legs is that this is the latest iteration of the well-known STAMPEDE trial, which has been going on for about 15 years. And the idea is they keep adding arms and then dropping arms depending on what works. And the latest arm is ADT plus Enza plus Abi in combination. And we will know eventually whether this actually provides a benefit. But I think it's certainly plausible that it will. So finally, just to summarize, minimizing adverse effects, which is what we all like to do. There's many kinds of intervention in men on ADT that can minimize effects. Intermittent therapy is one of them. And notwithstanding that Hirschman paper, I think the data is compelling that intermittent therapy reduces side effects of treatment. Hot flashes, you can treat in a variety of ways. Evening primrose oil for people who don't want to be on a drug and would rather be on a natural product. It contains phytoestrogens, which inhibit hot flashes. Diets to avoid the sarcopenia resistance training. Important to be the primary care physician for these patients. Promote a healthy lifestyle, smoking cessation, etc. The one I just want to talk about briefly is bone mineral density. So patients should be evaluated periodically with a DEXA scan. Calcium and vitamin D is the standard of care, although there's almost no data that this does any good. But what does is either a low dose of a bisphosphonate or denosumab every 6 months. And this is one study we did recently, a few years ago, once a week alendronate or Fosamax. And it's amazing how this is the placebo after 1 year, as expected, about a 2% drop in bone mineral density. 1 pill a week of alendronate, very innocuous, and actually the bone mineral density goes up. So I don't know why this isn't more widely utilized. The osteoporosis is a real problem with ADT. You can prevent this with 1 pill a week of Fosamax or every 6 months a dose of Prolia or denosumab. It's essentially, the data is quite similar, and we should be more on top of that. To summarize, it's a complex pathway, many resistance mechanisms that foil our attempts to eradicate these disease. Perhaps a more aggressive AR-targeted approach, androgen annihilation, will give us even better results, and that's currently being evaluated. I think most people accept now that for non-metastatic, rising PSA, long-term survival, there's benefits to intermittent therapy, and it should be, if not a standard of care, at least very widely utilized. The metastatic situation is a little more controversial because of the 9346 data, which did not demonstrate inferiority but was inconclusive. I think the thing is to pull out the excellent PSA responders amongst that group, where the PSA drops to very low levels. Many of them will have a prolonged off-treatment interval and benefit. If they don't have a good PSA response, they're probably getting chemotherapy in any case, and continuous hormone therapy is warranted. And finally, I think a change in practice should be to monitor testosterone as often as you monitor PSA. If the testosterone is not suppressed by ADT, now there's 8 papers suggesting that getting that T down is associated with a better outcome. Consider switching either to a different agonist or the antagonist. Try and do something to achieve the goal, which is, after all, low testosterone levels. Thank you very much.